Good morning, everybody, and welcome to the Global Surgery Grand Round. As I've always mentioned, that the Global Surgery Group is made up of 4 departments. It's us in NDS, it's anesthetics, it's a reproductive medicine and orthopedics working together. Today, we have 2 very interesting speakers. We have Mihir Seth and we have Anita. Mihir Seth is an engineer. And you might be wondering what is an engineer doing in global surgery, but we'll hear all about it from Mihir. So Mihir is at the moment a fellow in improvement and innovation in the OUH, and he also won a Young Investigators Award within our hospital, innovating on a neonatal little technical device. So we're very proud of you for having done that. He's co-founded a medical device company, and it's not high-tech stuff. He joins ward rounds on our neonatal unit, looks at all the machinery around the babies and see how he can make it very pleasant and easier for the babies as well as for the staff. So we are very, very pleased to have you in the hospital, but also amongst the Global Surgery Group. So, Mihir.
Thank you for those very kind words of introduction, Kokila. And I hope everyone at home can hear me. I'm just going to start sharing my screen. So.
It's got 25 people online.
Okay, great. That's really exciting. I seem to be sharing my screen. Everywhere except on my own screen. So just give me a second. Right. Right. I hope everyone can hear me online. If you can't, please put it in the chat and that will be fed back to me. Kokila, again, thank you so much for the very kind introduction and for giving me this opportunity to talk to all of you. So as Kokila mentioned, I've worked in medical devices, in medical device development in startups all over the world, in India, US, Kenya, UK, and Senegal. I was a Oxford Global Insight Fellow in 2020, was awarded the Innovate UK Young Innovator Award in 22, and have been appointed, and currently I'm working at the OUH as an Innovation and Improvement Fellow. So I'll talk a little bit about my work, but while I think what's important in my background and where I started with all of this is with a product called the Hemofuse. It's an autologous blood transfusion device. And the reason I started working with this company, it's a company called Sisu Global Health, is that even though they were based in the US, they were developing medical devices with and for clinicians in Ghana and Kenya. And as you can see, this was a very simple concept that they developed where patients with ruptured ectopic pregnancies or other massive internal hemorrhaging presented to the theater, and due to a lack of blood availability, there was no other way to help them. So they took a 500 ml syringe, put a filter in it, and using a simple pull and then push mechanism, they were able to salvage the blood and transfer it to a blood bag. So this is the work I was working on before I moved to Oxford and before I went to Senegal. And it really got me thinking as to what is innovation really, especially in the global surgery context. It's really important to think of what comes first. Is it the problem or the solution? And if you look at most medical devices right now, they tend to be more tech push. They tend to push a technology or a solution first rather than trying to actually find the core problem. And this often leads to situations where the technology or the innovation it's basically trying to hammer a square peg into a round hole. It's just really, really difficult and painful for everyone involved. So for me, good innovation follows this process, this sort of 6-step process, but it's iterative. And along the way, when you're interacting with stakeholders, it's about building trust. It's about empowerment, not just yourself as an innovator, but also the people that you're working with. It's your collaborators. something that's extremely, extremely important in global surgery. And I think Anita will be able to talk to that a lot better than I can right now. And I think most importantly, it's about recognizing that learnings happen two ways. As much as I am learning about the medical problems and the context that they exist in from the clinicians are also learning from me about how I'm thinking, how I might be approaching certain problems, and how I might be approaching the problem-solving mentality. So I'm going to keep the bottom graphic sort of, it'll be there throughout my slides so that you can see as I'm doing the work, as I'm giving you an example, what stage of the identify, invent, and implement cycle that I'm working on. So the first step is always to identify the problem. So as Kokila mentioned, I spend a lot of time in the wards. So in this particular case, I spent about 2 months in a neonatal ICU, shadowing clinicians, interviewing them, asking them questions. I've spent nights there, weekends, I've gone to day cases, also been on transport, intra-hospital transport, no, inter-hospital transport, so, and intra-hospital transport, emergencies, and just trying to understand the entire picture of what is happening, who is involved in various, in the various steps of the patient care pathway. And in each step of that pathway, what is the thing that's annoying them, that's causing potential harm to either the clinician or the patient. And through that, I compiled over 115 need statements. Now, the tricky thing with this, and as an engineer, it was really difficult for me to not think of solutions starting up. But over the course of time, like I've been trying to train myself to, and hopefully I've done it somewhat well by now, to not think of the solution. So whenever I look at a problem, I try and identify the problem. And I'll give you an example of that in just a second. But after those 150 statements, need statements had been compiled, I sat down with the people in the NICU to discuss, okay, these are 150 problems. Obviously, it's way too much for anyone to solve in a small period of time. So what is the most important thing to do? Or what are the most important things to do, and why? And most importantly for me, it was, why are these the most important things to do? And oftentimes the themes that came about were, it needed to be, well, obviously it had to have some benefit to the patient, either qualitative or quantitative. The tricky thing with neonatal patients is that the patients may not directly be able to tell you what they need or what they want, but from talking to parents, from talking to the clinicians, from talking to nurses, you get an understanding of what is good for the baby. And the other important things were, it had to save time. Clinicians, as we all know, are extremely overburdened right now. And it had to save the hospital money as well. So taking all of those factors in, the problem that I want to talk about today is a way to provide better visibility of neonatal veins for neonatal cannulation in order to reduce number of unsuccessful attempts by 50%. Now, that one sentence might sound really, really clunky, but it allows me to explain the problem to whoever I want, whether it's a neonatal doctor, a hospital administrator, a grant body, or even my parents. That one sentence allows me to explain to them what it is that I'm working on. And it interests them. And remember, I haven't even talked about the solution yet. And that is, I think, really interesting learning I've learned in terms of engaging people, because everyone seems to be interested in solving this problem. It doesn't matter what the solution is. They're willing to come with me on the journey to find that solution together. And I think that's been really, really powerful for me. So once we found that was the problem statement we wanted to work on, we tried to develop some success criteria. How would we know that whatever solution we developed as a group was successful? Obviously, it needed to make cannulation easier. And there was some criteria that were given in a qualitative way. And then some of the more quantitative stuff was, it had to be cheap, it had to be easy to use, and it had to be quick to use. So it had to add less than 5 minutes to the time of the clinician in terms of their regular cannulation. They didn't want to spend a day or multiple days in trying to learn a new method of cannulation. And it needed to be cheap. It needed to be affordable for them. They couldn't ask patients to spend hundreds of pounds on a new device that might, that would make it better for or hundreds of pounds, hundreds of dollars, that would make it better to cannulate. So we came to brainstorming solutions, multiple iterations, and these are just a few that I'm showing online. But my first thought was, if we needed to improve neonatal visibility, currently the method that's used is transillumination. So you're shining light on the neonatal hand from the bottom and seeing the veins on top. So my first assumption was that, well, if we are able to provide them with a more 3D perspective of the vein, so in terms of not just the XY location, sorry, this is the engineer in me speaking, but not just the XY location, but also the depth, then we might be able to give them a better way to cannulate, and as opposed to them either cannulating above or through the vein. And as I tried that, as you can see, one of the issues with it was that it was too bright. But regardless, I took this to the doctors to get their feedback, and it was interesting. They were like, "Yeah, this is a really, really good idea, but the sponge is nice and soft. Can you just make this instead? Can you just make a nice platform of like a spongy platform of LED lights for us to cannulate?" And that was really interesting. Now, just for context, this is a dishwasher sponge. This is not something that I would want to use in a clinical unit, but in terms of prototyping, it worked out really well. I just used some tubing. As you can see, I colored it with permanent marker to make a very, very easy, cheap, quick and dirty prototype of what a baby's hand feels like and what it feels like to cannulate. As you can see, I'm using a sewing needle as well. So prototyping or brainstorming solutions isn't hard. It's more about just trying to get your basics right and then just try iterating on it. So when I got this piece of feedback, like, oh yeah, the sponge is nice and soft, it really, really got me thinking, like, maybe I'm looking at better visibility the wrong way. Maybe better visibility is not just about seeing a vein in 3D or better understanding at what depth it is. Maybe it is just about understanding the context that they need this better visibility in. So as you can see in the picture on the bottom right, babies' hands, neonatal's hands are put in extremely awkward and painful positions so that the doctor can cannulate. With one hand, they are holding the baby's hand and sort of curving it around the light that you see on the top left image. They're also stretching the skin, and they're struggling against the baby because the baby wants to move their hand back because this is not comfortable for them. And then with the other hand, they're trying to find the vein and cannulate at the exact depth. So there's a lot going on. And if by chance the light slips away because it's a piece of plastic that's covering the LED, it can momentarily blind and disorient the doctor. So that, and as anyone who's been in the flow of things can say, like, if you're in the flow and you get distracted, it takes a bit to concentrate and come back. So with these couple of pieces of insight, I started looking around the neonatal unit and I found a sterile sponge. I found the exact thing that I was using, but in a safe way that the unit already had. So I was able to cut a hole in it, use it as a cover. And as you can see, even in adults, you are able to see the veins in the fingers. So we were able to do a quick test of this with a patient, and it was the first time we tried it. It was really, really heartwarming because we saw the neonate's hand literally curl around the sponge because it was a nice and soft surface. And it did not flinch, it did not move, it did not try and pry its hand away, right up until the moment the doctor cannulated. So at the moment that the needle pricked the skin, that was the only moment that there was any reaction from the patient. So that was a really, really good step for us because it validated the solution, not just from the clinician side who really liked it, but also from the patient side. So now we come to the point of implementing solutions. I think I always say it's one thing to come up with an idea and validate it, but it is another one to implement it. So we are currently running clinical audits with the help of the amazing doctors in the neonatal unit, as well as the support of the hospital administration to ascertain the exact time savings. And we are working with a sort of a region-wide network to help distribute and deliver this sort of simple innovation more broadly. So I think as engineers, even as clinicians, there's a lot to learn from each other in terms of how we innovate and how we go about the whole the problem-solving process. And I think working together is really, really key. I would not have been able to reach this solution without really amazing support and insight from clinicians. And I think it just shows it's a good example of how we can build off of one another. So as I finish my talk, I just want to leave you with this one graph where 75% of medical devices are built for and sold in these 9 countries around the world. And this is, for me, the one simple reason as to why innovation in global surgery is really, really important. There is so much that we can learn from each other, from other circumstances and other contexts, that I just want to change this graphic. And before I end, a quick question to everyone online and out here in the room is, as I mentioned, I've worked in a lot of countries. Which country do you think that this innovation was developed in? And yeah, that's more graphic images of medical device graveyards. Thank you.
We'll now move on to our second presentation, which is from Anita Makins. Anita is one of our leads in our global group representing reproductive medicine. Anita is the qualified obstetrician and gynecologist and also senior lecturer in reproductive medicine in this university. Anita has done a lot of work globally. She's been in low and middle income countries, especially a lot of work in Mozambique. She works very well with FIGO, which is the International Federation of Obstetrics and Gynecologists. And just to congratulate her on a recent award of a PhD. And today she'll share her PhD with us, which is based on postpartum contraception. Anita.
Thank you, Kakila. Can you hear me well?
Yes. Yes.
Great. I'm just going to share my slides.
Anita is currently in Brazil on a sabbatical.
Great. So hi, everyone. Sorry, I can't see you. I'm going to be talking about postpartum contraception globally and why I believe it should be everybody's business. So just a few sort of bits of data sort of backing this. So some of you may know this. I would have thought probably a lot of people don't. It's evidence that's been around for many years. But basically, if you look at birth to pregnancy intervals and the risk of adverse outcomes, you can see there that if women get pregnant with a birth to pregnancy interval of less than 12 months, their risk of miscarriage, low birth weight, maternal death and preterm birth are much increased, as the graph shows. Similarly, this graph is looking at birth interval of less than 18 months, comparing it to a reference of 24 to to 60 months. And you can see again that your risk of SGA, preterm birth, preterm SGA births, infant mortality, but also term SGA are all increased quite substantially too. So it's a greater risk to the subsequent pregnancy if it happens very quickly after the first pregnancy, is the overall message. You may have seen how these maps before, how you can distort them according to a particular statistic that you're looking at. So this one's looking at maternal mortality across the world, and you can see that the burden is much greater in low middle income countries. So you can see Africa overrepresented, Asia, Southeast Asia, overrepresented, and the North America and Europe, very, very small representation there because their rates of maternal mortality ratios are so much lower. And the reason I'm talking about maternal mortality is because if we look at key interventions for reducing maternal mortality, this paper was postulating that maternal mortality could be reduced by 30% just by using contraception, because you're addressing all causes. So the sort of circle in the top right corner is looking at the causes of death. So hemorrhage, unsafe abortion being the two biggest causes. Then you've got hypertensive disorder, maternal sepsis, obstructed labor, HIV, and others. But obviously, if you address the pregnancy right at the start and that you're preventing it, so you could have an impact on maternal mortality by reducing it by 30% alone with contraception. And then the next one down the line is addressing unsafe abortion, would reduce it again by another 13%. And then you go down the sort of looking at the individual causes of death and the reduction you would cause. So contraception not only improving the outcome of subsequent pregnancies, but also reducing the risk of mothers dying. And then this again isn't new data at all. This is from 2008, and it's looking at the percentage of children who are alive and not undernourished by duration of preceding birth to conception interval. And you can see there there's a direct correlation between the interval between the preceding birth and the chances of the child surviving, and not only surviving but not surviving undernourished. And this data was put together using demographic health surveys from I think 58 low middle income countries. So the chances of the child surviving, or the sibling surviving alive and undernourished, is much improved the longer the mother waits between her pregnancies. And what this guy said, Rutstead, in 2008, when he published it, was if all women waited at least 24 months to conceive again, under 5 deaths would fall by 13%. The effect of waiting 36 months to conceive again would avoid 25% of under 5 deaths. And the impact of avoiding these high-risk intervals would be a total of nearly 2 million deaths avoided annually in less developed countries. So kind of relatively simple intervention, but the impact would be huge. And that those numbers would not be that different today. So unsurprisingly, the WHO launches technical consultation on birth spacing, where they are recommending a birth interval of at least 24 months in order to reduce these risks, basically, so risk of adverse maternal, perinatal, and infant outcomes. So that's a strong argument for using for ensuring that women who want contraception have access to decent contraception and can use it when they want. And then there's the climate change argument. So it's thought that over the next few decades, emissions from low-income countries are likely to rise because of a rise in emissions per capita from rapid industrialization and increasing urbanization. So, and although current emissions per capita are much, much higher in high-income countries, overall emissions are expected to level off or decline as populations stabilize or decline. And a slower population growth could reduce carbon emissions globally by more than 40% in the long term. So basically what we've realized is that sort of as human beings, we're an incredibly successful species in that we've taken over our natural habitat. But I think there's a strong feeling that we've probably outgrown our natural habitat. And the issue is that it's to the detriment of the planet around us. And that it might be a little bit like we've pressed the self-destruct button. Well, certainly that's how it feels with the global warming, as I'd like to call it, which was the original term used, rather than this sort of climate change. And then interestingly, if you look at sort of these population pyramids, I don't know if you remember that, but some high-income countries are concerned that their populations are in decline and they're actually focusing on births. And I put here the population pyramid projection for Japan in 2050. And so you can see there how different it looks from the population pyramid for Nigeria in 2050. And the issue that Japan has is that it's going to have, because of their population, their fertility rate is so low, and their population receives decent healthcare, and so people live many years, is that they're going to have a sort of almost like an upside down pyramid, in the sense that they're going to have a larger dependent population and not enough young people to look after their elderly people in the not too distant future. So they're busy thinking that they need to promote births. When you think about the sort of distribution globally, to me, it seems to make sense that migration would be a much better solution, and that actually, for the first time probably ever, populations in low middle income countries are actually the solution to this problem. But it would only be possible if migration were allowed sort of freely. And as we all know, it's a very contentious issue, and politics makes it difficult for people to move freely across the world and perhaps fill gaps where perhaps you could say they're needed. So anyway, so because of all of these arguments, I think investing in postpartum family planning, it really makes sense. When we look at sort of cost effectiveness of different methods of family planning, so the graph on the left is actually a UK-based model developed for a nice guideline, and then and on the right it's looking it's actually cost effectiveness of contraceptives in the USA. But basically what it's showing overall, it's comparing short-acting contraceptive methods to long-acting contraceptive methods, and it's pretty clear that long-acting contraceptive methods are much more cost effective than short-acting methods. So although it's very cheap, for example, to buy the pill and give the pill, when you compare it in the long run to something like the coil, the intrauterine device could be the copper coil is the sort of most cost effective, but the hormonal actually contraceptive methods that are long acting, either the coil or the implants, are also more cost effective than short acting methods, and this is high income data, and we looked at it in low income countries and it was the same. So it's also a very cost effective piece of preventative medicine. So I got involved with a big initiative that FIGO, so FIGO is the International Federation of Obstetricians and Gynecologists, and they were given a very large multi-million grant by some anonymous donors to start an initiative around postpartum IUDs. So we worked in 6 different countries: Sri Lanka, Nepal, India, Bangladesh, Kenya, and Tanzania. And the aim was to try and get maternity services to counsel women properly about contraception. So talk about different methods of contraception that they may want, or firstly, do they want contraception, and why, birth spacing is such a good idea. And then if they did accept contraception, then which method would they want? And as part of their method mix, offer the postpartum coil. Because it is so effective, so the chances of getting pregnant if you have a coil in the uterus is less than 1 in 1,000, and it can be put in immediately after birth. So the idea is that if the lady's been counselled beforehand, she would like to have the coil, and we use the copper coil because in these 6 countries that was what was available in government facilities free of charge. So if they do accept the copper coil, then the baby's born, the placenta comes out, and the coil can go in as just one straightforward procedure. So a one-stop procedure, which is really valuable in countries where people travel a long way to access health. So it's trying to think a little bit more holistically about the woman, and not just, you know, her coming to give birth, but thinking about her other needs, and one of them being contraception. So we worked in 48 different hospitals across these 6 countries. Over 12,000 providers were trained in counselling, including community health workers, mainly in Kenya and Nepal. They were involved. So over 1,600 of those. And then we trained lots of healthcare providers in inserting the IUD, because it was a relatively, although IUD's been around for a long time and people know how to do what we call interval insertion, which is when women aren't pregnant, not that many people were trained in inserting it after delivery, immediately after delivery. So in total, over the period of the project, 701,000 or over 701,000 women received counselling, and 12% of those chose to use the copper coil. So over 74,000 women received the postpartum IUD coil over that period of time. So it was very successful initiative, and you can see there, you know, it's across 6 countries. This is one of our we had annual sort of south to south learning events where we got everybody together and talked about the complexities and how they'd overcome difficulties of implementing it in their different countries. So really a very much a sort of global endeavor, and the learning between the countries was really important, because contraception actually is quite controversial in many countries, and so not necessarily easy to implement, and the quality of counselling and so on was very important. So I just included this slide, which is about the complexities that we faced when we were counselling on contraception, and we did a lot of research trying to think of, you know, what was the sort of best method to use, and how should we counsel, or who should be doing the counselling, when should the counselling be happening, how often, and what kinds of counselling would we be giving. And what we found actually was that there wasn't a particular approach that suited all the countries, that it was very specific and culturally specific to each country. And the only actual factor that I looked at that seemed to be true of all the countries was that if you had the consultation about family planning on several encounters rather than just the one encounter, then the odds ratio of people taking it up was greater. And that would make sense, particularly when you talk about long-acting contraceptive methods, which you know means that women can be more reassured that the method's going to work because it's more effective and it's user independent and so on. If you want to talk about long-acting contraceptive methods, then you need to have more than one consultation. So you need to first tell them about the method, maybe first time around, get them to talk about it with their families, their friends, their husband, depending on who's the person who they would share that kind of information with, and then come back and then discuss it again. But just to give you some examples of the issues in the different countries. So in Nepal, we really needed the female community health volunteers to be part of the initiative. They weren't initially, we were working within the health system. So we were working with nurses, midwives and doctors. And then what we realized was that when the women went back to the community, if the FCHVs were very influential, and so they hadn't heard about the postpartum IUD, PP-IUD, and they were like, what is this? You should remove it. It's dangerous. We don't know anything about it. So getting the female community health volunteers was really important. In Bangladesh, for example, there were big issues with women accepting something like the PP-IUD because they had concerns about a Muslim burial being possible with a foreign device inside their body, that they wouldn't be able to be buried. And with maternal mortality ratios quite high, you know, when you're pregnant and you give birth, you're risking your life, and so the concern of what happens when you die is a really valid one. In India, there was a big issue sort of with women's autonomy. So in one of the facilities in West Bengal, the women were being counselled and they wanted to have they wanted to have the coil inserted. They had the coil inserted, but when they got home, when their husbands found out, they didn't discuss this with their family, with their husband in particular. When they got home and the husband, when they became sexually active, could feel the threads again, they were very upset and were going back to the hospital with them women saying, "What are you doing to our women? You don't have the right to put this in. You know, I'm the one that decides about their contraception or if they're going to use any at all." And so the hospital very controversially instituted a 3-way consent form. So it wasn't only that the woman signed the consent form, but 2 other people needed to sign the consent form. The second one was the husband, and the third one, believe it or not, was the mother-in-law. And so they wouldn't put the coil in unless they had these 3 signatures, and they were doing that to protect themselves because there'd actually been stories of assaults because the mother-in-laws and the husbands didn't know about what was going on. In Sri Lanka, the initiative became embroiled with ethnic tensions, and there was stuff in the newspaper about the government trying to control particular ethnicities with contraception, so trying to reduce the population of particular ethnicities by offering contraception to some groups and not to others, which was obviously quite bizarre and also very worrying. In Tanzania, we had issues with sort of political buy-in. So with the late president really was very much a pro-natalist, and he believed Tanzanian women should be having as many children as they could possibly have because they had lots of land and it needed developing, and so having a big population was good. And so, and it was so some of the healthcare workers, although there was this sort of what's the word, attrition almost between the healthcare workers and who understood the sort of scientific technical reasons why, you know, just getting pregnant straight away wasn't a good idea, and yet politically they were being told, you know, your contraception, we don't want you to be offering contraception to our women. In Kenya, there was an issue also with husbands' involvement. So if the husbands didn't know, then they would getting their ladies to have them removed when they got home after birth. And so counselling, couple counselling became really important. And when we developed counselling material, actually, the video that we developed in Kenya was actually 2 blokes talking about their wives' contraception. And that was the most effective way of getting information out about contraception, because at the end of the day, it was the husbands that were deciding. India and Bangladesh also incentives, so financial incentives to use contraception, not particular kinds of contraception, but contraception overall that's been used by the government of India and Bangladesh, a bit less so, but more recently now. And then I've put the UK in because when we did the initiative in the UK, we had difficulty, particularly from sort of senior midwifery support for an extra task to an already burdened, you know, group of healthcare providers, which are the midwives who are doing so much and who we have so few of. So very complex sort of area to work in, contraception. And some of the lessons learned, so these little ladies on the right, I used to call them the super nurses from Kalyani, but it's about really, you know, broadening a little bit the provision of contraception. So it's not just doctor-centric. So the insertion of IUD can be done successfully and was done successfully by the nurses in this one hospital. And you can see there's a graph went up there when the nurses became involved and learned how to insert the IUD. And actually, we did some studies looking at how good they were at doing it and the quality of the service they were providing. And so the chances of expulsion after they inserted it was actually lower than compared to the senior doctors inserting the IUD after birth. So just thinking about more broadly, because if you're not going to come across a doctor when you give birth because it's straightforward and you're in or out very quickly, then if only the doctor knows how to insert the IUD, then you're not going to have the opportunity to have it. Whereas when the nurses were trained to do it, then this became highly available. I talked a little bit about the cost effectiveness in high income countries in the 2 graphs looking at the USA and the UK. And so there was nothing actually about cost effectiveness in low middle income countries, so in poorer countries. So we worked on that and published a couple of papers actually, but what's interesting about this was we were looking at in the long run, you know, what was the benefit of using contraception, and we looked in Bangladesh and Tanzania at the costs of rolling it out nationally. And what we found actually was that we would save the government more money if it was rolled out nationally than it would cost them to implement it. So in other words, it was so cost effective, and because you reduce maternal morbidity and mortality and the effects I've talked about on neonatal health and infant child survival, your risk, your savings are more than your investment. So you can see there for Bangladesh, the total estimated cost was just under $2 million, but the direct healthcare costs saved were $2.6 million. And for Tanzania, the total cost was much greater in Africa when you compare to working in Asia. So it's nearly 7 million, and the savings would be just under $8 million. So not only, you know, so highly cost effective method, and actually saving governments in the long run. So getting that message across to ministries of health was really key in order to change policy on the ground. And so we did a lot of research in the different countries. When I say we did it, the whole point was that it was part of a team effort. And so in countries, we were able to strengthen their sort of research capacity quite enormously. And so we had lots of papers published locally and internationally, but by national authors rather than it being something that was coming from outside. These were research projects that were developed in country by the clinicians in the countries. And then the other really interesting thing that happened about all of this work was the south, what I call the south to north learning. So we talk about south to south learning. I know the Australians don't like it, but south to south learning, you know, is supposed to be when countries in the less developed countries are sharing their learning between themselves. But actually what happened very much in this project was a south to north learning. So what, for example, did the UK learn from what was happening in these 6 different countries? And I think, you know, because I was working across all of them, it was really obvious to me that there were things that had worked really well in these countries and that we could apply to our practice here in the UK and here in Oxford. So this sort of idea of reverse innovation, so the task sharing, so training midwives to actually provide the service. So an example of that in Oxford would be not so much with the coil, because we're just starting out with that, but very much, for example, with implants. So, you know, training midwives or the midwives on the postnatal wards to insert an implant. You know, they learn how can do Venflons and all kinds of other things. An implant is really not that difficult, but training midwives to do it, so giving them this extra role that they're not traditionally trained to do, you know, when they're training as midwives, means that the implant is far more accessible to women at home, to GP surgeries, but also actually on our postnatal wards has been key. And as part of this reverse innovation, actually, a professor from Scotland came out to Sri Lanka to learn about PPIUD, and they've started implementing that up in Edinburgh, which has worked quite well as well, including the sort of task sharing. And then the need for champions became really obvious as well. And I'll show you what's happened in Oxford in a little bit, and you can see what happens in the absence of a champion. But a champion is somebody who really takes the message on board and believes in what they need to do to improve a service, and then make sure that change happens. And that was really clear in several of the countries, that when you spoke to the right people or got the right healthcare providers involved, then that things just happen and implementation worked and it changed practice. With the absence of champions, it's really hard to get something going. The other thing that was really obvious was this need to integrate services. So I think that is difficult actually in the sort of structure that we work in here in the UK within the NHS, to ensure that services are properly integrated, particularly where we're working, for example, in Oxford at a sort of the referral centre, that we tend to just concentrate on our individual thing that we're good at or that we know how to do in a sort of highly specialized service, and we tend to forget about the more general things that need to be done, and contraception is an example of not doing the more general stuff. And then I talked a little bit already about the quality counselling for the uptake of the long-acting reversible methods. So in the UK health system, it was difficult to work out how we were going to get postpartum family planning going, because actually contraception doesn't really fit into maternity care or gynae, or hasn't previously. You know, it's either something that happens in sexual health, or perhaps something that happens in primary care. But actually postpartum family planning involves all of those three services, but they are bizarrely actually quite separate. So obviously the counselling needs to be done in primary care, but also in maternity antenatal clinics. The method being offered and given, the idea is that it's immediately postpartum, so that was then going to be a maternity issue, or for ectopic pregnancies or miscarriages, then it's a gynae issue. But then the long-term follow-up of these women, for example, with some of the methods, with the depot injection, the subcutaneous one, we need that to be continued in primary care. Or if there are issues with the coil and the threads, then that needs to be seen to in primary care, or sometimes if they're lost threads in sexual health. But getting these three different groups to work together to achieve this was actually quite difficult. So the barriers due to the complexity of work in super specialized high income services. So we've kind of lost this integration of services, which is very natural and very normal in low income countries. I think in high income countries, we've lost this integration, and we're very sort of, you know, protocolized and following our guidelines for that particular issue that that woman is there to see you with, and we tend to forget about the wider picture. So that was definitely a big barrier. And then I put a little picture here up of COVID, because actually COVID was quite an enabler with this initiative in the UK overall, but certainly here in Oxford, because suddenly GP, you know, during lockdown, GP services weren't seeing people as regularly, or certainly not face to face. So the access to contraception became limited. I think sexual health actually shut down during a period of time. And so this sort of obstetric encounter became a golden opportunity to access other types of help, because most women want to come to hospital to give birth, although of course there are home births as well. And so when they came to hospital, you know, this was an opportunity for them to have contraception. So right, we talked about it for a long time, but suddenly we're like, no, we really need to do this now. And so we did, and that was great. So it kind of really highlighted the need for integrated care. And the long-acting methods also, you know, highlighted their value in the sense that, you know, you wanted to reduce people coming in and out of hospital to get, for example, contraceptive methods. If you have a long-acting reversible methods like the coil or the implant, you know, you're talking about years before you have to have it changed again. So obviously reducing hospital encounters. And this is our graph of the postpartum family planning sort of initiative over time at the OUH. So you don't need to look at all the breakdown of the different methods, but if we look at the dark blue line, you can see there that during the pandemic, so March 2020, during the pandemic, as in the lockdown of the pandemic, March 2020 to July 2020, we were very lucky in that we had a designated postpartum family midwife. And so she was a midwife who was actually shielding, and she couldn't do face-to-face clinical work like she would have normally done. And so we almost had extra staff. And so we were allocated this midwife who could you know, go up and down the levels, the postnatal wards, and make sure that that it was being implemented, that women were receiving counselling about contraception, and that we were actually giving the contraceptives to those that are chosen. And so we were nearly up to 40% of women leaving with a contraceptive method. This is over births. And then that midwife, unfortunately, couldn't continue in that role, because when the lockdown was over, she needed to get on and continue with her other clinical work, and there wasn't the funding to allocate anyone specific. And so here's our champion, who then went missing, and you can see the drop there down to about 20%. And so then I was sort of plugging it. So who, you know, we need to get everybody else to make sure that they're doing this, whether or not there's a champion running up and down saying, have you done it? What have you done? And you can see there the little brips every time we have a new trainee doctor's induction. And you talk to them about how they have to talk about postpartum family planning to women, you get the little blips of increase. But I'm glad to say, so there's this sad sort of gradual decline, or we're at about 10% of women are leaving hospital with contraception. But I'm glad to say we are in the process of employing, we now have the funding to employ a designated postpartum family planning midwife, who I hope will turn this all around. So in conclusion, I hope I've convinced you that meeting the unmet need for contraception worldwide is achievable, and would impact positively on the development of the poorest nations, but actually benefit the richest by addressing climate change and providing solutions for dwindling populations. Sorry, I've talked for quite a long time there, but that's me